reason that they sound remarkably familiar. We were very fortunate when we got involved with the Studer Group that their pillar goals matched what we were trying to do. Okay, I'll quickly go through. This is from 2003 to 2008. This is what MUH was doing. Now, we were planning separately at that time. The hospital had its plan, the practice plan had its plan. We think they were complementary, but to some degree that was by chance. Accomplishments, we started MUSC Excellence in March of 2006. Service lines, somewhat controversial. When we developed them, we started in planned in 2006. We started in 7. We knew we needed an information system. We went through an RFP. We chose McKesson. I will point out that Epic did not bid on that. I think they were basically in their infancy, and they had just gotten a big contract with Kaiser Permanente. So they were one of the known company at the time. We know that because our board said when we went to the last session and asked to shift to Epic, the question was, well, why didn't you pick Epic in the first place? And the answer is they didn't bid. Ashley River Tower, opened in 2008. Since I give this presentation to medical groups also, we obviously want to talk about what the practice plan did. They, to their credit, I give Jack Poisner a lot of credit. He said, you know, we're going to open up 150 beds, and maybe we ought to plan to fill those. And we have. And the way it was done was a recruitment strategy that added 114 new positions. Part of our problem right now, with our downturn a little bit, I believe is we added all these positions in 2007 and 8 in anticipation of art. We really haven't added very many positions. In fact, we've lost some positions recently, so there is a plan to change that. Off-campus development, this little graphic that's here is the MUSC strategy. The Groper St. Francis strategy is we're going to build little hospitals around the community. The MUSC strategy is we're going to build outpatient centers for our faculty and bring everybody downtown. Somewhat significantly different strategies. They believe they're right and we're wrong, and we believe we're right and they're wrong. And so we'll have a chance to play this out in the marketplace. You're probably aware that the North Area Clinic, within eyesight of the administrator's office at Trident, opened in 2007, has been a success, I believe, by all measures. Okay, now this is continuation of UMA. They did buy land in East Cooper, and I live in Mount Pleasant, and I'm pleased to say that the road actually goes to the building. In spite of the appearance that the road is, there is no road, there is a road there. They're building a bridge, and when that's finished, it'll be a great strategy because it will end, 526 will end at the front door. But that didn't open until January. The building opens in the summer. At any rate, basically what East Cooper strategy is to consolidate a lot of departmental things that were distributed across the community and not focused in an area, and were all different leases. And so this is a very effective way. And the other thing UMA did was hire a chief financial officer and a chief technology officer, which is another way of saying an information officer. Those were done in 2009. Now, I'm almost finished with the history of this. These are the things we've been working on in 2010 and 11. This is sort of a joint thing, if you will. Grow complex care. We realized, we probably instinctively knew this, but we were given some very powerful information from the University Health System Consortium that says the patients that are referred in, that come from outside the Tri-County area, are our most lucrative. They have high-end referrals. They have a tendency to have a little better insurance mix than the ones in the Tri-County area. And if you don't have a lot of referral business, we won't make it if we're nothing but a Tri-County facility. Now, we're not going to be that, but we're trying to focus on that, and there's something called destination programs, and there are a lot of efforts within the service lines and the departments to do that. So we want business from all. We don't mind business from the community, but we won't make the kind of money that we need to make. Hospital cost structure, I believe it's been 2 years since the accountable care plan was passed, but we all have heard, I'm sure you have heard, we need to manage the Medicare rates. Exchanges are coming, despite the fact that South Carolina's chosen not to put one in. The federal government's going to put one in, most likely. And when that happens, commercial rates will come down, and we won't be able to cost shift to the commercial insurance. We have to cut our costs. Quality, transparency on the website, everything is out there. We're getting reimbursed on that. We wanted more integrated outpatient hubs like Mount Pleasant. Primary care development is kind of interesting. We've been hot and cold on that. We almost sunk the UMA in the 90s by investing in the primary care network. It was the rage at that time. We were going to all be rich because we were going to sell all these primary care doctors. And the health care plan wasn't implemented, and all of a sudden the primary care doctors' practices were a burden to us financially, not an asset. But the reality is that every time you see one of these plans come up, and when I heard the accountable care plan, I had two reactions. One was, I've heard this before. It was the same, essentially a dressed up version of the Clinton health care plan. What it says is, until we manage populations, until we get away from the fee-for-service mentality, will never bend the curve. So we're going to get there. Well, the way you manage populations is the primary care base. That's our Achilles heel in my opinion. So we need to continue to develop that. We need what's known as a chief medical information officer to manage our implementation of our IT, and we needed to continue in this MUSC excellence. So, accomplishments, in the last 2 years, we've been dean, Gary B is retired, Bob Warren is the chief medical information officer. This summer, I think East Cooper outpatient will open. UMA has bought land in West Ashley, trying to anticipate a similar outpost. Now, seventh floor of art. Some of you may be more involved in this than the others, particularly if your office is on the 7th floor of art, because we are planning to convert that to beds, which was the original plan, and that's a good thing to have a problem with, and that is because we've recruited enough patients that we need that. So we're working on that. Phase 2 is women's and children's. We're working on a study for that. I think everybody's familiar with 5 and 5. And ideal care is something we're working on, which is sort of the next iteration of quality. And then tomorrow, my strategy tomorrow is to duck. Because I'm sure everybody knows we're rolling out Epic tomorrow. I've talked to enough faculty members who came here from other places that have Epic. Every one of them says it's worth it, it's painful, but once you get it in place, you won't believe that you ever live without it. So it's really powerful. So stay with that, encourage people to train, and we'll get through it. One downside to this is that the recommendation from EPIC is to reduce the size of your outpatient activity, cut it in half. It's supposed to be back up to full amount within a month or so, but it's going to have an impact on our financials because we get a lot of admissions out of outpatient. So we're going to see, I think the rest of this year financially is going to be a challenge. These were the challenges that we're facing today. These are the things that we looked at when we went through the strategic planning process, and I'll go through in a little detail about the process we went through. Let's talk about the challenges, because I think they're very pertinent today, because while we faced many challenges in 2000, they were primarily leadership change and the fact that we as an institution didn't have any money. Those were very important, but they weren't as driven by the economy or the economic balance. Actually, the Balanced Budget Act of 1997, which was wonderful for the economy except for health care, really had sort of hammered us. And from 2000 to 2007 or 8, health care was sort of rocking along like it used to, grow a little bit. pass on some stuff to commercial insurance, and everybody was fine. But that's changing, and I don't think there's any question that it's unsustainable, so we're seeing some challenges. Okay, these are summaries, but I think they're important. One is competition. I've usually worried about MUSC because I've always felt like we were sort of our own limiting factor. It's hard to get in this place. We just corrected our own problems. The patients were there and everything would be fine. I'm not sure the patient population, I don't know that that's the right answer now, and I think the competition is pretty severe. You've seen a ramp up in ads. We're guilty. One of the things that we did in this process was talk about the fact that people don't know what's at MUSC, we need to elevate the brand. But we've seen the reaction. As soon as we ramp things up, we open an urgent care center for pediatrics in the North area, and voila, North Trident is the place to go for your pediatric emergency care. And that, I'm sure, was in direct response to that. Okay. The other thing that's happened is that Roper St. Francis has bought up a lot of practices. They're up to about 200 owned practices. We know firsthand how that can affect us because they bought a two-person practice that did hand surgery, and with their insured employment agreement, they moved all their cases. And that's 600 cases a year that moved from MUSC. It's really had an impact, particularly in the ambulatory surgery area. So the competition is real, and it will have an impact. Consumer expectations, I think people now demand more. There are all kinds of things on the web, and you can find out things about it. Unfortunately, that strategy is somewhat limited still because people still go where their doctor tells them. And I'm not sure that's going to change, although I think it's shifting more. I think more people are shopping and looking at ads and looking at results. But unfortunately, the relationship between the physician and the patient is very strong, and when the physician says, go to Roper or go to MUSC, people are going to be compliant with that. Capacity constraints. We've got capacity constraints. Our physical facilities are stretched. Our financial constraints are there. We need to build cash. We need to build performance. Or we won't be able to borrow money for phase 2 or borrow money to buy equipment. Systems. We've been here, as I say, for a long time, and one of the things that's pretty clear is that MUSC is not based upon a long tradition of information systems and standardization. Everybody does what they want to do. For example, scheduling, physician scheduling, by and large, all physicians control their own schedule. That's almost unheard of in academic medicine. One of the things we suffer from is access, and you can't get, if you're a new person in the community, a new patient to our system, it's very hard to get in. So one of the strategies we'll talk about briefly is access, and one of the ways, we know the answer to that. You take control of the schedules, and you say, you're going to have to leave openings every day for new appointments. They don't want to do that. They don't want to be sitting around twiddling their thumbs, so they fill them all up with return visits, and the economics of that are pretty clear. You make money on new patients because they're the ones who need the care, follow-up visits, or follow-up visits. Regulation. Dr. Poisser here give you a tutorial on the different things called the genome so I'll spare you that, but suffice it to say there are a lot of regulations. Decrease in reimbursement, Medicare and Medicaid is starting to fail. We took a 7% reduction in Medicaid this year. That means for the work that you did this year, it's the same as last year, we get 7% less money. That means 5 and 5 becomes 1.